Good afternoon, everyone, and welcome to our third presentation in our Reducing Preventable Hospital Readmissions webinar series. This is a webinar series where we're focusing on some targeted strategies for improving care transitions in our Virginia hospitals. My name is Joyce Dayvault, and I'm the Director of Performance Improvement here at the VHHA Center of Healthcare Excellence, and I am your moderator for today's presentation. Before we get started, though, I'd like to go over just a few housekeeping items with you. As you'll see here on the slide, this webinar is being recorded, and we will be posting the webinars on our Quality Excellence page at our VHHA website. The presentation is located in the handout section of your webinar that you can download, and we ask that you please use the phone option. All participants in this webinar are muted. And we ask that you're not raising your hand, but asking a question in the question box as we come to that at the end of the program. And we also have a feedback survey at the very end that will launch at the completion of the webinar. And we ask for your input to complete that because that helps us to ensure what we're doing is meeting your needs, and also appreciate your input and feedback for future webinars. The purpose of our webinar, of course, is in this whole series is to share successful strategies used in our Virginia hospitals and health systems to improve care transitions and reduce hospital readmissions. We also want to increase transparency and facilitate networking among our Virginia hospitals, our health systems, and our community partners. And here on this slide, just for your information, are the webinars that we have currently completed and the ones that we're looking forward to providing for you through the end of this year. Today's presentation is being brought to you from Sentara Leigh Hospital. The pharmacy care transition team members that will be presenting today are Catherine Collins. She's a PharmD and clinical pharmacy specialist in transitions of care at Sentara Leigh, and Catherine Flowerhoff, who is also a pharmacy D and is the team coordinator. At this point, I'd like to turn the program over to our two presenters, Catherine. And Catherine, the floor is yours.
Thank you for that introduction. Today we'll be talking to the group about improving patient safety with pharmacist-led discharge medication reviews. Next slide. Sentara Leigh Hospital is a 250-bed community hospital. We are magnet designated. During the week, we usually have 6 deployed pharmacists, and they each cover approximately 35 beds per pharmacist. And our average length of stay is typically about 3.4 days. And then just to kind of give some perspective on our discharges, we have about approximately 40 acute care discharges per day. Next slide. This slide just kind of gives an overview, a timeline, and perspective on the background and history for our transitions of care program at the system level, as well as both at the local level at Sentara Leigh. And so I'll start kind of from the left-hand side. In 2013, the System Pharmacy Medication History Technician Program was developed, and this was mostly focused on obtaining accurate medication histories for patients being admitted from the emergency department. So our medication history technicians were placed in the emergency department to gather those med histories. In 2015, a couple years later, we had our Sentara to Home outpatient transition services implemented. This is our meds to bed program. And over the course of the years, as our transition of care program has expanded since implementation of Sentara to Home, our inpatient pharmacists have worked closely with the pharmacy technician transition specialists when reviewing patient discharges to identify any medication barriers at discharge. In 2016, we had Epic in-basket best practice alerts developed. And at this point, this BPA acted as a trigger to identify patients discharging on high-risk medications such as anticoagulants or insulin. And at that point, we would review the patient's profile for all medications to look for any discrepancies or interventions that we wanted to make to the team based on that BPA. In 2017, the System Pharmacy Transitions of Care program, or the team was developed, and they developed it best practices at that point. and they finished the design stages of the system TOC program. And some of the examples of best practices included focusing on really 3 main buckets, and that was obtaining an accurate medication history, optimizing inpatient therapy, as well as addressing compliance barriers, and then focusing on the discharge process, being discharge medication reconciliation by a pharmacist, and of course our Sentara to home meds to bed delivery of medications. And then in the summer of 2017, we implemented at Sentara Leigh Hospital our centralized order entry in preparation for our local TOC rollout. And that was really helped redistribute duties for pharmacists that covered the floors, so our deployed pharmacists, and that would allow for more transition care or a clinical focus at that point, because they would not also be tied to the orders, reviewing orders too. And then prior to the pilot starting in 2018, the TOC design team also had support from IT. They helped build the TOC scoring system, which we'll talk about, and prioritize patients, as well as an interactive dashboard in Epic to help improve efficiencies. And at that point then, in the first quarter of 2018, the pilot for our new TOC workflow occurred at 3 Sentara hospitals, 2 being community hospitals, and then 1 of those hospitals was our large academic medical center in Norfolk, Virginia. And then what we did there is we used our lessons learned from the TOC workflow pilot and many training sessions locally that we'll touch on to lead us up to the go live for our local Sentara Leigh TOC rollout in May of 2018. Next slide. Part of the redesign prior to the rollout, we did a lot of background work to prepare the staff. So we had many TOC presentations to educate them. There were about 4, and I'd say they were probably 30 to 45 minutes, and they focused on the TOC initiatives that we'd be really hitting home with, such as our medication history review process, the discharge process, and then pulling it all together for an entire review of the patient. We also streamlined consults in pharmacy education, which we'll touch on the next slide. We encourage use of patient lists in Epic, and really what this meant was we used a system standardized list that had standardized columns that would incorporate all needs real time for the pharmacist, so they wouldn't have to be clicking back and forth. We adjusted the deployed pharmacist coverage, which we'll touch on, and we motivated staff. And probably, I think this is probably the most impactful change, really, to be honest, from our standpoint, because what we did is we kept the staff engaged after the go live. And the way we did that is we established an internal department goal based on the system pilot data, and we sent out weekly emails with our progress. So we touched on discharge medication reviews, how much we completed each, not only at that week, you can see in the table there, but also how we compared to that year to date. And then our intervention rate. So this would be interventions that the pharmacist would recommend to the provider. And then at that point, we also were able to document and collect the acceptance rate of those interventions that the provider accepted, essentially. And then it's a little hard to read, but at the bottom of that example email there on the right-hand side, we had safety catches, and these were highly impactful safety catches that we interpreted to cause patient harm if otherwise not caught, that could cause patient harm. And so really it was very eye-opening when we shared these at our local huddles and at our hospital admin huddles, how much pharmacists were actually catching by doing this. Next slide. Part of the workflow optimization that was touched on previously was to be able to add more to the pharmacist's plate. Not only did we centralize order verification, but we also looked at low value added clinical activities that really didn't have an overall impact that was significant. And so we streamlined consults that pharmacists were reviewing daily as part of their workflow that didn't add value, such as things that were already protocols, nursing-driven protocols. We also focused on looking at our education process from a pharmacist's point of view for anticoagulation, and we were able to streamline anticoagulation education by pharmacists for patients that were already on anticoagulation prior to admission. And we engaged nursing, and they were happy to continue providing this service. And so pharmacists just focused on new anticoagulation education. And by doing that, we reduced educations completed by pharmacists by 80%, and in turn saved about 40 hours of pharmacist time per month. Next slide. This is an example of our patient lists in Epic. And what we did was we broke our TOC dashboard up into two main sections. So on the left-hand side, you can see the inpatient TOC workflow. And that is, something day-to-day that we looked at. Looking at the columns, we of course looked to see if they had an accurate medication history. Probably the best row to look at would be the top row. So if you have a patient come in, they had a medication history done by a technician, that was a check mark. The TOC score helped stratify patients based on risk. So we had a red, green, yellow, red being the highest risk patient from an internal TOC score perspective. If we needed to review those patients, and we did, and we left handoffs, and that icon would be able to tell us that. And then also if they had any high cost medications that we identified early on and would want to proactively see would be covered at discharge, we looked at that via the RX cost evaluation. And then on discharge, we also looked at that first row is probably a good indicator of an optimal patient, a best case scenario. If they had an active discharge order, they had a CAR. We also prioritized patients that had completed medication reconciliation by the provider with a check mark. They were high-risk discharge because they had a red dot, and then they also had prescriptions at Sentara home identified with that icon with the bag. So all of this incorporated into one patient list really helped streamline our workflow on the floor. Next slide. This slide here depicts how we were able to identify areas of focus to help us figure out how to adjust pharmacist coverage based on where TOC services were needed. So if you look at the graph on the right-hand side, you can see at the bottom on the x-axis, those are the floors, and the floors highlighted with the red box there were floors that we anticipated had a high readmission rate, upwards of 14 to 16%. These were our medicine patients. And so we wanted to make sure we redistributed workflow to be able to allow for those TOC services on the floor. So the table you can see there is the average number of beds covered by each individual pharmacist. And for the floors that would have heavy TOC impact, those patients, there are probably about 24 to 32 patients covered by one pharmacist, which then allowed them to do their TOC services. And we'll go to the next slide, and I will transition over to Catherine.
So this slide depicts the increase in the discharge medication reviews that we completed. Prior to our change in workflow, the Pharmacist-Led completed approximately 300 discharge medication reviews per month, and those were identified based on the in-basket BPA, so most of those reviews were retrospective. After adopting our new workflow, we immediately saw a threefold increase in the number of discharge medication reviews completed, and this increase has been sustainable for over the last year. Our monthly average is very consistent and hovers close to 1,000 discharge medication reviews per month. Next slide, please. Please note that this slide includes our overall hospital readmission rate. Prior to go live, our 3-month average overall readmission rate was 14.8%. Our most recent 3-month average readmission rate is 12.8%. So that's leading to a 2% reduction in our 3-month overall average readmission rate since the implementation of discharge medication review. And it's also interesting to note that our readmission rate, it continues to go on a downward trend. Next slide, please. This table summarizes some of our most common errors encountered during discharge medication review. So wrong dose, duplicate medication, and omission comprise the most frequent discharge errors. So examples of interventions made by pharmacists during discharge medication review include some of the examples listed at the bottom. Sorry, just a second here. So we had a patient who was admitted for a hypertensive emergency. So metoprolol was added to the patient's prior to admission blood pressure medication list, and it was unintentionally held on discharge. The pharmacist contacted the provider, and metoprolol was restarted on discharge. Similarly, a patient was admitted for urosepsis. The urine culture grew Pseudomonas. The patient was on appropriate IV antibiotics when they were inpatient. When the patient was converted from IV antibiotics to oral antibiotics on discharge, the patient was placed on an antibiotic that doesn't cover Pseudomonas. The pharmacist noticed the discrepancy and contacted the provider, so Augmentin was changed to Cipro, which covers Pseudomonas. These are just a few examples that really highlight the impactful work that pharmacists are doing when they're completing discharge medication review. Without a pharmacist intervention, these patients easily could have been a readmission. Next slide, please. On average, we complete discharge medication review on 70% of all of our patients who are discharged. And recently, approximately 81% of our high-risk patients who are discharged. And our high-risk patients, we identify those as patients who are on anticoagulants, insulin, oral hypoglycemic, or who have a high risk of readmission. Our intervention rate averages close to 14%, and our acceptance rate is about 71%. With the number of discharge medication reviews completed in the last 12 months and our acceptance rate, we've prevented over 1,200 medication errors. Our medical staff has been incredibly supportive. We really appreciate their support. The physicians have been very receptive to our interventions and to our discharge education, and without their support, our program would not have been as successful. Next slide, please. After the TOC pilot and the rollout at Leigh, Sentara initiated prospective discharge medication reviews across the system. After tracking the number of discharge medication reviews completed at each site, a decision was made to establish a system goal to complete discharge medication reviews on 67% of high-risk patients who are discharged. So as mentioned earlier, high-risk patients are patients who are identified as on an anticoagulant, oral hypoglycemic, insulin, or they have a high risk for readmission. The specific discharge goal varies slightly by site. It depends on how quickly the site adopted to their discharge medication reviews. So the overall average completion rate is 67%. We developed a red light, green light report to track the progress toward the goal. In addition, Sentara Home, which is our outpatient pharmacy, transition specialists are developing a documentation tool to help facilitate communication between both the inpatient pharmacy and the outpatient pharmacy to make discharge smoother. Next slide, please. Currently at Sentara Leigh, we're working to try and identify transition of care issues prior to discharge. Several months ago, we rolled out high-cost medication lists, so we're encouraging all of our deployed pharmacists to run the list daily to identify potential high-cost medications prior to the day of discharge. By determining a patient who has a patient's copay earlier and potential adherence issues due to cost, we hope to increase compliance with patients when they're discharging on medications, so we're sending patients out on medications that we can afford, and we're hoping that it will also affect our length of stay by identifying potential barriers to discharge earlier. We're also encouraging pharmacists to prioritize reviewing high-risk patients. We want the pharmacists to review these patients prior to our MDRs, our multidisciplinary rounds, and we want to identify any medication regimens that can be optimized on these patients. We're also encouraging pharmacists to prioritize based on length of stay, so pharmacists review patients with a lower length of stay prior to rounds, patients that may not have been reviewed by a pharmacist before, and then that gives them a chance in rounds to reconcile any medication history discrepancies. So we're working towards resolving some of those issues on the earlier side. We are also a large orthopedic hospital. As such, we have a large number of orthopedic patients who are discharging on warfarin for 3 weeks for post-op DVT prophylaxis. Currently, all of these patients receive anticoag education from a pharmacist because they're all new start anticoagulants. Most of these patients, though, are discharging to a rehab facility for physical therapy, so they won't be in charge of their warfarin therapy on discharge. So we're exploring the option of having nursing perform anticoagulation on these patients to allow pharmacists to have some more time for TOC activities. In addition, we're striving to improve our handovers to the post-acute providers, including the patient's PCP, the skilled nursing facility, and our Sentara anticoagulation clinic, where in order to provide these handovers, we're using the Epic inbox messaging to relay pertinent information to these post-acute providers. Next slide, please. So in summary, after adopting a new resource-neutral workflow, we've resulted in an immediate threefold increase in the discharge medication reviews, which have been completed, and we've been able to sustain this increase for the last year. Since implementation, we've also achieved over 1,200 accepted discharge medication interventions. Next slide, please. In addition, our overall hospital readmission rate has declined by 2% since implementation of discharge medication review, and it continues on a downward trend. This concludes our presentation. Thank you for your attention, and we're happy to answer any questions you have.
Thank you so much, Catherine and Catherine. We're now monitoring the question box, so if anyone has any questions for our Sentara Leigh team, we ask that you would enter them at this time. We have one comment for the team. Great presentation. Thank you very much from Mount Vernon.
Thank you.
Thank you.
One of the questions here, I'm waiting for us to open up the box. What pain points have you experienced during this process?
In my opinion, I think in order this was a huge change for pharmacists in general to adopt this mindset, to look at patients from an admission to a discharge and then anticipating discharge needs probably starting on day one of their admission. From a provider standpoint, realizing that we really had to work with both pharmacy and providers and really try and triage the most important interventions to make with them. So an example, at first we may have had pharmacists calling on a Tylenol 500 milligrams Q 6 hours PRN, and something was wrong with the order. Maybe it didn't have the PRN on there or something to that nature. And that wasn't very highly impactful, and so we had some growing pains with that. Casey, did you have any other?
Yeah, I think that one of it was a huge change in mindset for the pharmacist. Like, I agree with Kat that it was, we really had to sell the why to the pharmacist, why this is impactful. And I think the weekly email highlighting some of those impactful catches really encouraged the pharmacist to accept this new workflow. And a lot of them felt like they had to review these discharges, because if they didn't, there could be some significant medication errors on some of their patients. So it really gave them the why to, encourage them to do this, to adapt this new change in mindset.
Great. Another question that we've received is, who looks at the stoplight through the day, i.e. like which team members?
So I look at the number of medication reviews that we've completed each day. Are you talking about the discharge, who completes the discharge medication reviews? That would be each deployed pharmacist is responsible for all of their discharges on their floor. So we have 5 pharmacists on the floor that are assigned to each unit, and they complete the discharge medication reviews on their unit.
And our hospital, too, is striving to try and identify patients for discharge earlier. So, for instance, the day before or the afternoon before, and just try and really think about what is holding them up for discharge. So sometimes, the pharmacists come in and they start their day by looking at the list and seeing if there's any cars or discharges early on in the day, instead of waiting until 11, 12, 1 o'clock, because we're really trying to strive to identify those patients earlier.
Good. Another question has come from 3 different questions from one person. It says, what was your overall readmission rate, all cause?
Prior to go live, it was 14.8%.
Okay. And then what was the readmission rate after all of your changes?
It was 12.8%. The most recently rolling. Mm-hmm. It's all cause.
Well, that was a yearly rate?
It's a 3-month rolling.
Oh, the 3-month rolling, okay. Another question is case management involved in this work with you?
This is mostly pharmacist driven. However, we do engage case management when needed. So if we notice, there's a high cost medication that's delaying discharge or would potentially delay discharge, and we needed patient assistance form filled out, that sort of thing, we would engage them. But that is probably our partnership at this point with ICM.
Okay. Any other questions from the attendees? Oh, here's another one. Yep. Is the TOC score red, green, yellow in EPIC in the patient list of available for more than just pharmacy?
I think they could wrench it in, yes. So there's nursing would have the opportunity to wrench that in. I don't know if we've been very successful with that. They have another score that they look at that they've kind of adopted as well, and it is more nursing driven focused. This is more focused on medication-related transition of care interventions in high-risk patients.
Okay. Any other questions from attendees? Okay, thanks. One more. Would you describe the steps taken to get buy-in for the RN nursing-driven anti-coag education?
So when we broached the subject, we brought all of the nurse managers and educators from each of the floors together, and we had a meeting with them. And we really highlighted, at that point, we'd looked at some of the discharge medication reviews, so we had a few examples that we could show them of really impactful interventions that we made. And we, explained that in order to continue to make these impactful interventions, we needed some more time to do that. And nursing at the time, they were educating patients on anticoagulants. Prior to discharge, they did it in their discharge education, so it wasn't necessarily an increase in their workload. And that when they saw some of the impactful interventions that we were making, they realized that they were more than happy to accommodate.
The other thing I would say to that is, selling it as there was really no change to their workflow. It just us wasn't doing additional work. But also, we were tracking prior to this change how many patients were receiving education in general at discharge. And we had a goal of greater than 95%. And what we found after the change, and we relate to nursing, was there was no decrease in the number of educations being provided to the patient. So we, quote unquote, remained in the green for that goal. And so that satisfied, their concerns as well.
Excellent, excellent. Any other questions? We have about 3 minutes left. Okay, if there are no further questions then, and I appreciate all of the interactions and the questions were very appropriate and helpful. I just want to take time now as we conclude to thank Catherine and Catherine for their excellent presentation and informative information today, and for taking the time out of your very busy schedules to share your strategies in improving care transitions and reducing preventable admissions and for reducing patient harm. Many thanks to you for this time. For our I'm trying to get back. Can you close that up for me so we can get to our last slide? All right. So our next presentation will be July the 25th at the same time, 12:30 to 1. And again, thank you very much, Sentara Leigh Pharmacy Transition Team members, for your excellent presentation today. This concludes our presentation. Thank you.